Hi, I'm Dr. Gary Schwartz from Associated Eye Care, and this short presentation is on the management of ocular foreign body. So the first thing we always consider with a foreign body is where on the eye is it? Is it on the surface somewhere? And it can be under the eyelid, what's called the palpebral conjunctiva. It can be on the white of the eye, what we call the bulbar conjunctiva, or it can be on the cornea, or it can be in the eye someplace, and that's a penetrating injury. And here it's a more significant injury, obviously, and the type of injury is more like hammering or getting struck in the eye with a BB or a small projectile or something like that. So here's a quick review of the anatomy, and you see the eyeball there, but what I like about this picture is it also shows the eyelid, and the front surface of the eyelid is skin, and the back surface of the eyelid is the conjunctiva, and then the front surface of the eye also has this conjunctival coating on it. So here we see a palpebral conjunctival foreign body. So this upper picture shows a foreign body on the eyelid that's been everted upwards. It's being held up with a wooden Q-tip, a cotton tip applicator. And these patients will often say that they feel better, like if they pull the eyelid away from the eye, or if they look in a certain direction, and that can give you a clue that there's a foreign body under the eyelid. So for instance, this patient, because the foreign body is on the temporal side of the lid, if they look nasally, if this person looks to the right, then the foreign body will be rubbing against the conjunctiva where they don't really feel it, rather than the cornea where they feel it. So they might say, gee, as long as I'm looking to the right, I feel pretty good. This bottom picture shows vertical scratches in the cornea with fluorescein staining, because every time they blink, they vertically rub this foreign body over their cornea. So if you see vertical scratches like this, it should make you think of, maybe there's something under the eyelid, I should go look for it. So how do you look for it? Well, here's how you evert an eyelid if you're not used to it. This is one of these techniques that you should get good at. It's pretty easy to do, and it can be very useful. So A shows you have the patient look down, and you put a Q-tip or something where the fold in their upper eyelid is. If I'm using a Q-tip, I actually prefer the wooden end rather than the cotton end because it's a little smaller and a little firmer. What B shows is now you grab the lashes with your other hand, and C, what you're doing is you're pushing down on the Q-tip here with the teal arrow, and then with your other hand you're kind of pulling up over it. And then you take the Q-tip away, and now with one hand you're holding their eyelid up with the lashes, and with the other hand you can use an instrument to pull away whatever foreign body happens to be stuck there. It's a really slick technique, and it really does work well. So we just talked about if something is on the palpebral surface of the conjunctiva, but there's also this other part of the conjunctiva which lines the front surface of the eyeball. So where the green shows you where the palpebral is, the blue points to what's called the bulbar conjunctiva. And you can get foreign bodies in the bulbar conjunctiva also, and here's a couple of examples. This really looks like it's just something just stuck on the surface, which with forceps or a Q-tip or something, you should be able to remove this one pretty easily. This one's a little sneakier. This has a fair amount of hemorrhage around it, which gives the impression that maybe this one goes a little bit deeper. And you have some bleeding between the conjunctiva and the sclera, and you might be fooled. You might go to grab this one, and when you go to grab the foreign body, it's right there, you can see it, but it's hard to remove it because it's actually under this layer of conjunctiva. So here's where this one would be. So it's under the surface. So some of these foreign bodies are stuck right on the surface. They're pretty easy to get, but if they're under the surface, they're a little trickier, and then sometimes we have to go at the slit lamp with forceps or even a needle to try to dig it out. And that might be a little bit more advanced than what a lot of non-eye doctors are used to doing. So here we have a couple of foreign bodies of the cornea. Now, these are pretty easy to see. The one in the top left, what you see is it's not very reactive. You've got this brownish thing that's stuck on the cornea. It might be organic. It might be a non-reactive metal. It could be plastic. If this is just stuck on the surface, this can be very, very easy to remove. And again, you can use a Q-tip, you can use like a spud, you can use a needle. If you use a needle, go big. The larger the needle, the easier it is to get things like this off. So I would always recommend like a 19 gauge or bigger rather than like a 23 or 25 gauge. The picture on the bottom right shows a metallic foreign body that's brown, and it has an annulus of white material around it. And that white material is just inflammatory material that's kind of, it's actually melting away part of the cornea. And that's called a rust ring. And sometimes this can make it harder to remove all of the foreign material. So in the top left picture, it looks like one solid thing. You just pluck it off and it's gone. Whereas in the bottom right picture, it's a lot of times it comes out in pieces, or you can remove the foreign body, but you're left with that annulus of stuff that has rust or bits of metal that are kind of stuck in it. The general rule with these is if these are left to sit a couple of days, it's actually easier to remove the stuff because the corneal tissue gets a little mushier. So these aren't, even though they look kind of weird, they're not emergencies per se, and sometimes they actually do better if they are allowed to sit for a day or two. But it's something that we're going to have to remove completely eventually. So when it comes to removing a corneal foreign body, my advice is, do whatever you as a provider are comfortable doing. If you feel good around the eye and you can pick up an 18 gauge needle and, go at it, do it. But if if a Q-tip is all you feel comfortable with, then don't go any farther than a Q-tip. There are Dremels, there are spuds, there's all sorts of things that are available to try to remove some of these foreign bodies. If you get it all off, basically treat it like a corneal abrasion, send the patient home on some topical antibiotics, maybe some painkillers. If you can't get it all off, for whatever reason you gave it a valiant effort, but there's still some stuff left behind, then just feel free to refer so we can evaluate and try to get rid of anything that's still there. If the foreign body ends up deeper in the eye, like the top picture, or in the orbit, like the bottom picture, that puts them in a different classification, obviously, and this is an emergency. These are usually fast-moving, usually metallic types of things, so hammering metal on metal, getting hit with a BB, something like that. Plain films work well to prove there's something there, but they don't help localize them well, and obviously you want to avoid an MRI if there's concern that it's something that may be magnetic. So let's leave you with just some takeaways, some pearls. One is, just like anything else with the eye in an emergency situation, if discomfort is making it difficult to examine the patient and treat the patient, put some numbing drops in. We're not sending patients home with numbing drops, but using numbing drops in the clinic or emergency room setting does make it easier to evaluate somebody and then to treat them. Get a good history. If someone says, I have metal in my eye, there's a difference between I was grinding and there was a lot of metal dust in the air, and I was hammering and I felt something hit me in the eye. So get a good history will tell you a lot of times how worried you need to be. Do what you feel comfortable and competent doing. If a Q-tip is all you feel comfortable with, then use a Q-tip. But if you feel pretty good about using a needle or a spot or a Dremel, do it. The eye can take a lot. The eye is one of the few organs that's exposed to the elements daily. It's not protected by the rib cage and skin and things like that. It is out there on the surface, so it has been built to last. So you can be a little bit more aggressive a lot of times than you think you can be. The eye can really take a lot. Unless the foreign body is intraocular or intraorbital, these are not emergencies. A lot of rust rings, like I say, actually do better if they wait a day or two. And regardless of how big it was when they walked in and what's left after they leave, they're not going to feel better immediately after removal. They're oftentimes going to feel the same leaving our clinic as they do arriving because they come in with a foreign body, but they go home with a corneal abrasion. The palpebral ones, on the other hand, where they have that foreign body under the lid that scrapes every time they blink, those guys feel remarkably better leaving. And I usually won't numb their eyes so that they can really feel the difference when I take that thing off. And it kind of makes me feel good when they say, oh yeah, you got it. So a lot of times I won't numb the eye for those. One last piece, which sounds a little odd to hear, is if the patient usually wears contact lenses, have them wear it while they're healing. A lot of times the contact lens will act like a bandage and help them to feel better. It doesn't help them heal quicker, but it can help them feel better. And a lot of times we'll actually use a contact lens as a bandage after doing these to help a patient feel better. So that's a quick rundown of ocular foreign bodies. I hope you found this helpful. Feel free to reach out at the email listed here if you have any questions or comments or have any ideas for future topics. Thanks.